I'm very humbled by where we are today, and just very thankful for the presentations, and it leads into, I think, a question that I have put forward with a group of people that I've worked with for a number of years, and that's the argument that we need a national Indigenous organ donation and transplantation think tank. And so I just want to show you a picture here, some pictures of where I'm from. So Métis women do not go gray, we go blonde as we get older. So if you're wondering about the blonde Métis, well, here's a little bit about who I am. I grew up near Batoche in a Métis community called MacDowall, and so these are some of the pictures of where I grew up, and I love the picture in the corner of my dad and my brother, because I think it shows kind of Métis people, you know, pictures of my dad and mom and my grandmother and my sister and I, and in the middle, and my son. So I have a Tunisian son, so he's part Arabic and Métis, and yeah, so he's like this beautiful global child, now a grown man, and yeah, so I just want to acknowledge him as well, and all the support that he's given me. In the middle is the picture of our think tank that we started. Mike Moser is on the one end there, and Dr. Moser is a very close colleague of mine, and I just love working with Mike, and he and I decided that what we needed to do first in terms of organ donation and transplantation in Saskatchewan was to pull a group of people together, which we did. This is the group of people. Many of them are knowledge keepers and elders, First Nations and Métis, living donors, donor recipients. And we really wanted to build collective intelligence by creating a think tank and really giving us space and room to think about the issue. Most of us going into it at the time, with the exception of the healthcare providers and those with lived experience, really didn't have a lot of background in organ donation and transplantation. And this is the members of our team. And we stayed together for 3 years and met pretty much on a monthly basis. COVID happened, which opened up an opportunity for us to go online. That was a bit of a challenge around the technology of getting people so that we were comfortable. You know, many of us would never have shown, I would never have wanted to be in front of a camera with my computer as much as I ended up being. And I think other people feel during COVID, you just get used to it, right? But at that time, it was all brand new. But what COVID allowed us to do was to pull in people from across the country. And some of you are here today with us that came and presented to this group of people. So it was really about having this interface between First Nations and Métis people on the think tank with people who are working in healthcare. And so we would have, before COVID, we would meet in person. And this is a picture of us meeting in person. And I think we were waiting from somebody from Nova Scotia to talk about the deemed consent legislation. I think that's the day that we had that. And I'm not going to go through this. We've heard a lot today, you know, around the issues that are unique for First Nations, Métis, and Inuit people. And I continue to say First Nations, Métis, and Inuit because I really firmly believe in distinctions-based approaches. And our leadership, our Indigenous leadership, are reinforcing that, you know, and there's all kinds of issues that we need to consider, including geography, health jurisdiction, who pays for what, how is that paid for, what are people negotiating, you know, as we've heard from our speakers, what are people negotiating in order to get treatment, and so, as I said, the think tank. I mean, I've worked in mental health and addiction for years, and nothing was more frustrating than to be pulled to some city and put into a hotel conference room and given flip charts and asked to solve the issue or to give direction on, say, youth suicide, right, in our communities. Because one of the things that happens at a local level is that there's constant change at local levels in terms of what is happening and how healthcare funding is flowing, what's happening locally with the people. And so sometimes in those contexts, I felt like we were a little behind what was actually happening on the ground. But one of the things that that context of the flip charts and what I call flip chart fatigue is that it didn't give us time to be thoughtful and reflective and to have that back and forth dialogue. So the think tank was really a way to examine a complex health issue that wasn't receiving any type of attention, really from health within the healthcare system, but also from our Indigenous leaders as well. There was limited attention. And we wanted to look at it outside of a healthcare crisis, so that we weren't being pulled in because there was a crisis, but because it would give us time to think. It gave us a safe space to share and support one another. And it really gave that relationship building. And I don't know whether John Gill is on in the meeting today or not, but I'll never forget what John said to us one day. He said, I can go to cultural safety training and I can go to cultural safety training, but I can never learn what I can learn from sitting and being with all of you and listening to you talk to one another, right? And that was one of, I think, the benefits of the think tank was that people who were coming in who were healthcare providers in transplant medicine were able to hear the dialogue between our First Nations and Métis peoples and how these issues were being thought of. And Celia was part of our think tank as well as Terry Gardner, who was our elder. And so this idea of having a national think tank and moving forward with a national think tank, I think is very, very important because we were able to pull out certain things out of the think tank that pushed, I believe, transplant medicine in Canada, donation and transplant medicine in Canada. And one of the things that I want to say is that the reception by the donation and transplant world, so to speak, in Canada, the systems that exist was incredibly positive. And so I have to thank people for that type of reaction that we received, and that we were able, I think, to build awareness now within transplant, within donation and transplantation. However, one of the things that I don't think that has happened quite yet, and I really thank Chief Philip for his leadership, is that we haven't, this work has not captured the imagination of our First Nations, Métis, and Inuit leaders, health leaders. And the reason for that is simple, is that there has been so many things on their plate, including COVID and post-COVID, not to mention, some of the challenges that are being faced through addictions. And the other day I Googled, I was putting together a paper and I looked at life expectancy, and the life expectancy of a First Nations man in Canada is 60 years old right now. And that's just, I couldn't believe it, that it's dropping, right? And so you can tell that our healthcare leaders have a lot on their plate. So one of the things that a think tank can do is it can create collective intelligence. So I would say in some ways, transplantation, of course, is a modern phenomena, right? This is something that, is relatively new. And so for First Nations, Métis, and Inuit, we need to build collective intelligence around the equity issues of culture and how we understand that. I think there's a lot to be done in terms of the determinants of health, all of these things that can be informed. And so one of the things that would be a priority of the think tank, and the think tank, the idea of having a national think tank that would be driven by First Nations, Métis, and Inuit, is that think tank, one of the first priorities would be around data. We don't have healthcare utilization data. We don't have a lot of data. And the problem is when you don't have data, it's like it doesn't exist. And I believe, Chief Phillip pointed this out, that there hasn't been the attention because it hasn't had the profile. Organ donation and transplantation has not had the profile. And so pointing to what we don't know, right? So as we've been making arguments over the recent years for improved services, is that we don't know how many First Nations, Métis, and Inuit people currently have end-stage organ failure. We don't know how many of them are making it onto the transplant list. We don't know how many are not making it onto the transplant list and the reasons why they're not making it on. We don't know how many are choosing just to give up and not to seek treatment because of all the things that Celia talked about and Jake talked about, with all of what a person is up against. And we don't know, whether people are lingering longer on the transplant list. So there's a number of things that we don't know that we really do need to have data. And you'll hear from Cindy Moriarty coming up around data and that. And so as I talked, so we can look at postal code as kind of a surrogate for some of the data, but it just really means that we just simply don't have the data that we require. And that has to be definitely one priority. And then again, going back to our speakers this morning is that inequity that exists, right? And we really, as Celia pointed out, if the North is your norm, we need to begin from that place, not to begin from the needs of Southern hospitals or Southern transplant programs, for instance, but we really need to look, if the North is your norm, what are the things that we can do to support patients? And so we really need on this think tank people with lived experience, people that are living in circumstances where there are these added challenges. One of the things that I think the think tank can question governments on is that we hear often politicians and others talking about the idea of equity, that everybody in Canada deserves equal access to healthcare. And so the question for a think tank would be, do they really believe that? So do our politicians, do the people in charge of healthcare really believe that equitable access is achievable? And if they don't, then that's really a form of systemic racism that's so entrenched that we're not questioning a statement like that. So what then, the think tank would really look at, what does that equitable access look like, working with people such as Celia, Chief Phillip, and others, to look at how do we address those equity issues that are unique. And Jag pointed out there's ways in which we could do that. So I just want to talk a little bit about how a think tank works and the ways in some of the things that came up in our think tank that I thought were quite unique and really speaks to the value of having that time to meet together. And I should add, before I go on, because I haven't said this, the makeup of the think tank ideally would be made up of Indigenous healthcare leaders. It would be made up of people with lived experience, including patients and family members. It would be made up of people working in the medical system. So it would be, as you saw with the previous think tank, a combination of people. But the idea in which the think tank is most valuable is that we have people working in healthcare. We have First Nations and Métis people with lived experience that would come and present to the think tank. And we would be able to have this back and forth dialogue, but also that they would have the opportunity to return, and so that we would have spaces for observers to come and observe what's happening in the think tank. So it would be very fluid. And the idea is that we would inform mainly the First Nations, Métis, and Inuit healthcare leaders so that then they can go forward in their conversations with government, in their conversations with policy makers, and to argue for services, supports and services to be improved. So this question came up in our think tank. It was a Facebook post from a woman who was from a reserve just outside of Saskatoon. And she said, I would donate my organs if I could donate to another Indigenous person. And so I brought this back to the think tank and, so should we have an Indigenous organ registry? And as some of you who are here that were at that meeting will remember, there was a division between some of our people. So some of our people said, no, that's not our value, that we believe in giving to everybody. And one of our elders who was a really strong, a very powerful voice in our group said, hey, wait just a minute, we don't have equitable access. And so until we have equitable access, having an Indigenous organ registry may mean that it may reduce the inequities of our people. And so this debate went back and forth between, and it was a very proud moment I felt for our group, because we saw our people working through, working through this question. And at the end of it, came to a consensus that really an Indigenous organ registry maybe wouldn't be the appropriate thing. But nevertheless, that equity issue, everybody agreed that was primarily that we needed to reduce inequities. And so I think, it served as a really good example for those who were there as observers to see the ways in which we work through these complex issues and the ways in which the values of the people coming out of the cultural values were able to be used to come to a consensus. David Dennis, who we heard about earlier, I love activists. I like to think that I'm a little bit of an activist myself. And Mr. David Dennis taught us a huge lesson in Canada and was really the driver, I believe, his push to have a national discussion about the 6-month rule, abstinence rule for liver transplant. And so I want to acknowledge him. And then also, he asked us this question, and I don't know the answer to this, but it's a really important ethical question. And rather than just talking about the individual challenges that people have and even the systemic issues that exist in our healthcare system, he put us in a different context. And he asked us this ethical question that if colonization created the optimal conditions for First Nations, Métis, and Inuit people to have elevated rates of alcohol and drug use, and then you withhold the very treatment that you need to save those lives, should that not be something that is considered more than just equity issues, right? And so he really pushed us and pushed the transplant world, I think, to think about colonization and to think about why is it, that we have these elevated rates. And I won't go into more detail, but I want to highlight the role of our activists, of our Indigenous activists, and how important they are for transformational change. And so I really believe that we do need to have those activists as part of this think tank and respect why activism has played such a key role in transformational change over time. And as you know, Mr. Dennis, as we heard from Chief Phillip, that filed the human rights complaint, and we will, that's pending now, and we will hear the outcome of that at some point in time. But I think that his role cannot be underestimated. And so the last thing I'll talk about quickly is presumed consent legislation. So I haven't heard a lot about presumed consent legislation recently. Presumed consent legislation, of course, is that everyone is considered to be an organ donor unless they opt out. This seems, in some ways, for many people, this seems like a no-brainer, right? So it seems like legislation would make sense. You increase the number of people who are organ donors. This was adopted for the first time in Nova Scotia, has presumed consent legislation. It was, I believe, is still being considered by other provinces. And so when I looked at this issue, one of the things that we talked about at our think tank, and this was an issue that was brought back to the think tank, is that is there a duty to consult with Indigenous people? So for healthcare legislation, there isn't, but it is good governance. And so there wasn't consultation with Mi'kmaq people, for instance, in Nova Scotia. So when I talked to colleagues from Mi'kmaq Health, they didn't know that this had even been passed. Now, I think there's been work on that now where there is maybe more engagement and involvement. But if the equity issues are not addressed, and this is where, if we had a national think tank, we would be able to think through these issues systematically and to be able to inform our Indigenous leaders. So if equity issues are not addressed, what we could end up is more First Nations, Métis, and Inuit people becoming organ donors, but the equity issues preventing them from being organ recipients. And we also need to consider the backlash. So there is still a significant amount, as we've heard from people, a significant amount of mistrust in the healthcare system. So I do have in my research people saying to me, I'm afraid to sign my donor card for fear that they won't give me appropriate end-of-life care because they want my organs. So there is this level, quite high level of mistrust that people have. So when you put into play a legislation like this without education, without being informed on some of the fallout that could happen, you could end up actually having people a backlash against this type of legislation. So what are the lessons that can be learned is we need inclusion of First Nations, Métis, and Inuit people in decision-making tables, right? And so we really need to support. That means providing money to organizations to be at those tables. We can't expect our Indigenous organizations to have available people, because they're already stretched so thin. We need increased attention to this issue. We need patient-driven research, and we do need more research, and we do need a distinctions-based approach. So yeah, so thank you. So that's, I think that kind of wraps it up.